Hello, everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today, we will explore key behavioral health CPT codes in practice. Our experts will share insights on the codes that physicians and care teams can use when providing screening, treatment, or preventative services, and how those codes can support more timely, whole-person care for patients. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. And let's just take a moment to go over your experience today here as an attendee. If you're joining us on Zoom, welcome. You will see a dark menu bar either at the top or bottom of your window. Should look similar to what is on the slide right now. There you can access a selection of resources related to this webinar, including links to our BHI CPT coding guide and today's slides. There's also a link to stepsforward.org where you can find all of our past toolkits, podcasts, and webinars. If you don't see those options, select the three-dot More button to access the resources and the Q&A box. If you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom, access the resources, and ask questions for our speakers to answer. After the webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the resources tab to the AMA EdHub and claim credit there. We'll remind you of all this at the end, and for now, I would like to introduce today's speakers. Joining us today are Leslie Prellwitz, Sulamita Camargo, and our moderator, Chris Botts. Chris, I'll pass it right over to you.
Thanks so much, Alec, and thank you all so much for joining us today for our live discussion, where we'll be focusing on providing an overview of upcoming behavioral health CPT coding updates, sharing specific examples of how codes work in practice to help enhance patient care, and discussing how to optimize revenue cycle management for behavioral health services, including potential opportunities to prevent and avoid frequent coding errors. Before we dive into today's discussion, I'd like to briefly introduce our two guest speakers. First, we have Leslie Prellwitz, who is the Director of CPT Content Management and Development at the American Medical Association's Health Solutions Unit. Her work focuses on setting the strategic direction for production and maintenance of CPT content, as well as serving as secretary to the CPT Assistant Editorial Panel, or Editorial Board, and providing advice on the proper use and application of CPT to key stakeholders, including educational content presented in CPT Assistant, clinical examples in radiology, and other AMA coding products. We also have Sulamita Camargo, who is the Senior Director of Finance for Health System Integration at the Meadows Mental Health Policy Institute. She has over 13 years of experience in medical billing, finance, and project management, and in her role at the Institute, supports the policy implementation team to advance collaborative care and measurement-based care in primary and health system settings. And as Alec noted, I'm Chris Botts, Senior Manager here at the AMA, and I will be the moderator of today's discussion. As a reminder, we will reserve about 15 minutes or so at the end of the discussion for your questions. So please use the Q&A box to share any questions you may have as we go through the discussion, and we will get to as many as we can in the limited time we have today. So with that, welcome again, Leslie and Sulamita. It's great to have you both with us here today. First to start, Leslie, can you give us a brief overview of the current BHI coding landscape, along with highlighting the key BHI-related CPT coding updates?
Okay, great. Happy to do so. Well, congratulations, and thank you so much for having me here today. Let's go ahead and we'll talk through some of the CPT codes and some of the additional changes that are here. Let's go to the next slide, if we can, please. And the good thing about CPT codes is that they really allow for a variety of types of care that's provided to behavioral health patients, really spanning across a continuum of care. So when you want to think about something that's provided from a very isolated individual environment, all the way over to something that is truly collaborative, because as we know, oftentimes behavioral health and other medical conditions can sometimes coexist. They need to be co-managed in the best interest of the patient. And the good thing is that the CPT code set really encompasses all of those different areas. We're going to talk about them today. We've highlighted them here from the most isolated on the left, all the way over to collaborative care on the right. We have included some G codes, some HCPCS codes, recognizing that there are certain instances in which those codes need to be reported, particularly for Medicare beneficiaries. We'll have limited focus on them today, but did want to recognize that in our current coding scheme, sometimes you need to use one or the other, or sometimes both, to report care for a patient. So we wanted to make sure that we recognize those. Let's go to the next slide and we can talk a little bit about the codes primarily on the left-hand side. So this is really the co-location ones where you don't have a lot of deep integration of medical and behavioral health, but it's designed to engage patients earlier in the care continuum, perhaps before they need to get to those more complex settings. And some of these codes are really, because they have less integration, it's easier to incorporate these in a smaller setting. You don't have to have a large infrastructure to be able to understand this. So preventative medicine codes, certainly preventative medicine, think about it. The idea of getting and working with the patient before you have a particular issue. And so many of those are individual or group codes. And the good thing about these codes, at least for 2025, is many of them have remained quite stable, which is also helpful, with a little bit of additional emphasis on telemedicine, by the way. We'll get to that a little bit later. There's also some specific factors here around behavior change interventions. So while preventative medicine may encompass more of a medical perspective sometimes, there are certain ones around behavior change, such as tobacco and smoking use cessation counseling visits, and the alcohol or substance abuse structured screenings and brief intervention services. Now, the good thing is that not only are the codes stable, but I talked about telemedicine, and you'll see in these slides a few areas where we put either a letter T or a 93, and what that indicates is that those codes can be used and reported in a telemedicine environment in addition to being in person. 93 refers to our modifier 93, which allows for codes to be reported audio only. So it really helps to expand the availability of these services for patients. And a lot of that, of course, as we all know, came out of the pandemic when telemedicine became a necessity for so many, but also understanding that care is provided in different ways. And to be able to expand and flex with the way care is delivered today, the CPT code set has been able to move on and expand those additional care settings as well. Let's go to the next stage where we're not quite as isolated, but now we're going to be moving towards co-location, but now we have more of a behavioral health focus. It still doesn't require a larger collaboration, but it's a little more segmented and focused on behavioral health. And there are particular codes, particularly around psychotherapy, will be your main codes in this area. So we have codes for psychotherapy, as you see, 30, 45, 60 minutes, again, with telemedicine and audio only as options, as well as psychotherapy when it's performed in conjunction with an E&M service. So regardless of how the patient needs that particular care, whether it's by itself or with an E&M, the CPT code set accounts for both of those. It also accounts for group psychotherapy too. In terms of behavioral screenings, this is where a few more screenings and assessments start to come in. So things like a brief behavioral and emotional assessment, as you've noted here, with the scoring and documentation per instrument, CPT code set allows for those types of assessments as well. So it starts to broaden a little bit more and give more options when it comes to behavioral health specifically. Now we'll move to the next slide. And this is really sort of the middle range where we start getting into adaptive behavior, additional screening services, developmental screenings. And again, within the code set, there's instructions on all of these in more detail, but also the administration of a caregiver-focused health risk assessment, because oftentimes when you're providing care to a patient, it's not just the patient, it's their environment. And so thinking about checking in with that caregiver can also be important. And so the code set actually allows for that as well. Again, even within those telemedicine and audio-only services if need be. Next slide. We'll be talking a little bit more about the adaptive behavior services. So now it's a clear focus on behavioral health, and there's a broader range of roles that are involved in some of these codes. So you have a physician or qualified healthcare professional versus perhaps a technician who's performing a certain type of assessment and going on. So our adaptive behavior services are focusing on assessment and treatment. They're designed to assess deficient adaptive behaviors, maladaptive behaviors, other impaired functioning secondary to deficient behaviors, and its interactions and implications for care. The health behavior assessment and intervention codes, these came on about 5 years. They're still here, again, with options for individual, group, and family, because all of those different aspects can be important in providing comprehensive care to a patient. And it's really looking at those psychological, the behavioral factors that are complicating medical conditions and treatments. So now you're starting to blend the medical and the behavioral health sides together, which is really the purpose of those particular assessment and intervention codes. I think some additional codes that we have are on this next page. And if we'll move forward to that one, let's see. All right. Care management codes. So you've noticed our little yellow bouncing ball on the top has been moving farther towards the right. So now we're really looking at more expansive coordination models and physicians or other QHPs guiding the work of a defined team. So this is for slightly broader or more complex structures, but it looks at items like general behavioral health integration care management. Lots of words, but the idea is that many of these, you're thinking about a longer range of care, more individuals involved with the care of the patient. So you've really got two aspects here. You also have things like interprofessional digital services. And so even though you may have a number of specialties or groups in one particular group practice, you may have a need to reach out to additional specialties or getting additional insights and assessments on the patient. Those interprofessional service codes are designed for communication between a consulting and a treating physician. Patient is not present, but for them to be able to have that conversation. And sometimes that gets very detailed. You may need to go to a deep subspecialist, and it allows for that. It also allows for time for the treating physician, if necessary, if there's extensive time required to get those codes together, that they're able to do that as well. So it gives options for both of those areas. Let's go to our next slide then, and we'll talk a little bit more about how these are kind of coming together. So our cognitive assessment and care plan services, again, this is not necessarily new for 2025, but it's really when you need that comprehensive evaluation of a new or existing patient and you're requiring it to establish or confirm a diagnosis and really start thinking about planning before you get into the treatment itself. Also, the collaborative care general management for Medicare and the psychiatric collaborative care models for Medicare services. We've noted those HCPCS codes here as well because we recognize, again, for some Medicare patients, these may be codes that are needed to be reported. And so it really fits on this end of the spectrum. Let's move to the next slide. And really, this helps just to provide a synopsis of the telemedicine aspect. So the benefit is that of all of the different codes that we've discussed here, we've given you a quick cheat sheet of which of those codes from a CPT perspective may be reported either telemedicine, and we'll call telemedicine as audio and video, telephone audio only, or can be reported in either environment, in addition to in-person. So the codes that are in green are the ones that are audio only, and you can definitely see that the trend when it comes to psychotherapy codes or telemedicine codes in this set instance is really to have those codes that are able to be reported from CPT using under Appendix P, that's modifier 95, that's audio and video, or many of them are also listed in Appendix T, which is modifier 93, which also gives you the option to report audio only if that's the venue that is available and appropriate from the physician's point of view, that that's the way that care should be delivered. So it gives you a lot of additional flexibility in those earlier areas to help and provide interventions much more facilitating than having everyone have to come into the office all the time. So it gives you some additional flexibility that we didn't have before. Let's go to the next slide. I think that's the highlight. Okay, telemedicine and virtual visits. I did want to give just a brief note on virtual visits, and this is a question we get often, because when it comes to reporting certain types of visits and certain types of CPT codes, those in the evaluation and management or E&M section, there are reporting requirements or guidelines primarily implemented by CMS in terms of who may report E&M services. And that is a limited set of clinicians who are able to do that. What I've done here, though, and what CPT has done, and I wanted to highlight, is that there are some instances in which some of these codes may fall under the E&M banner, and as such may only be reported by a limited set of clinicians. And in some cases, CPT has actually created mirrored or parallel codes outside of E&M that may be reported by those professionals who are not eligible to report E&M services. And so I've just given you the quick cheat sheet here. So for our audio video codes, there are listings for physicians or QHPs who may report E&M. And then for qualified non-physicians, which in many cases, depending on your definition of QHP, may include either psychologists, social workers, other individuals who may be of importance in this area. There are parallel codes that may be used in many cases to report the same types of services. Now, the rules aren't exactly the same, but we wanted to make sure that we had a reporting mechanism for those who could not report E&M visits. And that includes the synchronous, the telephone visits, as well as the online visits, the digital portal codes. So there are parallel codes outside of E&M that are available for use. Next slide. I think we have a little more about the virtual visits. And the only item I wanted to note here, and we've gotten more codes about this as well, is whether or not the telemedicine codes, the new codes that were introduced in 2025 that you see here, the question is, are those reportable with the psychotherapy codes in the medicine section? The short answer is yes, they are. And there is, we'll talk a little bit more about it, there was a technical correction that was issued in early March that these codes had initially been left off of the list of eligible codes you could report those psychotherapy add-ons with. And I'm happy to report that, yes, you can. I believe that goes back to January 1st as it's a technical correction. And we can put some resources later on in the chat if people aren't sure of where that is. But it is possible to report the telemedicine codes for those payers that do accept them with the psychotherapy add-on codes. And so your telemedicine environment is preserved for those payers. Chris, I think that's the majority of what I wanted to go over in terms of the codes. The only other item I would note, and I don't have a slide for it, is that while we're talking about coordination of care here, certainly, and many integrated services, there is a set of codes around remote therapeutic management. We didn't go into it today because it's really not directly related, but there is a code around remote therapeutic management having to do with cognitive behavioral therapy. And I would strongly suggest if that is something that is of interest or in use in your practice, just to note that it is out there, it is in the medicine section. And all I can say is watch this space as many people are reporting, are preparing their responses to the preliminary rule with CMS. We here at the AMA, we're also preparing to release the 2026 code set. And I believe the official distribution date is tomorrow. So I can't tell you exactly what's there, but I would say if you're interested in RTM, you might want to take a look and see if there's something of interest to you for 2026. That's about all I can say. So with that, I'll hand it back to you.
Fantastic, Leslie. Thank you so much. And thank you all so much for your questions that you're already putting in the chat. I know we'll try to get as many of them. Leslie, real quick, before we move over to you, Sulamita, I have a couple quick ones. One, for those that may not be familiar with the term co-location, can you provide a quick just definition of what you're referring to when you mean co-location and that kind of schematic that you went through for those codes?
Sure. When you're talking about co-location, it's really a pretty basic setup in that you may have a situation where you have a behavioral health specialist or someone else who is either physically close to the primary care office where most of the care is being delivered. They may not necessarily be integrated from a business standpoint, although sometimes they are. But that's probably the earliest type of integration where you're physically next to each other. You may not have any more of a business relationship than that, but that's what we're referring to with the co-location moniker.
Fantastic. And I know you listed a few specific types of QHPs. Is there a specific list that folks can go to or some other place for them to be able to fully see who is categorized as a QHP?
Right now, the AMA, we do not keep a separate list of QHPs, and I'll tell you why. Because oftentimes when we look at the definition of a qualified healthcare professional, and I can certainly drop that one in the chat a little bit later, some of that is specific or maybe influenced by scope of practice laws in a given state, within a given facility. And so we give outlines of what a QHP is. We step a little farther away from a specific list because I personally have had that question for a couple of different subspecialists or certain types of clinicians, and I've seen it acceptable in one state. You cross a state line and then it's not. So we want to make sure that we keep that flexibility and we don't step over those scope of practice rules. There is a general definition to be used, but that's one of the reasons why it's not listed, because it can vary by state or facility jurisdiction and what they determine.
Well, we'll circle back. We keep on getting more and more questions, so we'll see what we can get to. But Sulamita, I want to get back over to you and all the great work that you all do at Meadows. How do you all see practices utilizing these existing codes that Leslie had outlined? How have they helped enable more timely access to the needed mental health care that patients desperately need as they are interacting with various different physician practices?
Well, first, thank you, Chris and Leslie. I'm honored to be virtually sitting next to you both and having this important discussion. So, here at Meadows, we've really worked with practices across a wide range of specialties, not just primary care, but also pediatrics and women's health and dental and FQHCs and RHCs. And what we've seen is that they use collaborative care and general behavioral health integration codes, some of those that Leslie reviewed earlier in some earlier slides, to deliver fully integrated behavioral health services to patients who really need them. So the strength of collaborative care, that's not just consultation or not just co-location like we just went over, it's that it's structured, it's population-based, it's data-driven, and team-driven, right? So that structure is what helps close the gaps that other models often leave behind. And because that physical health and behavioral health providers are working together in a very formal, systematic way, it really helps improve coordination. And that's really what gets patients connected to the right care sooner in a more seamless way.
And I want to be cognizant of time because it's flying by, but I wanted to touch on because I'm sure it's on top of mind for many folks, given the recent 2026 physician fee schedule proposed rule, where CMS proposed creating some optional add-on codes to the Advanced Primary Care Management or APCM services, specifically HCPCS codes G0556. 0557 and 0558 that would facilitate providing complementary BHI services by removing time-based requirements that currently exist for BHI, specifically collaborative care codes. CMS noted that they believe by removing those time-based requirements that will reduce burden by reducing documentation requirements for billing, which CMS expects will make primary care physicians more likely to furnish BHI and COCM services within the APCM services. So I wanted to just throw it to both of you all just to get your general senses of kind of key considerations of the proposal, understanding there's an open comment period, and I know both of our organizations will be providing those publicly in the coming weeks. But if there's any additional thoughts that you all have that would be helpful for this audience, if implemented, do you think this would have the intended effects that CMS is looking for? And are there any unintended consequences of the potential implementation of these types of codes? So I'll open it up to either one of you if you all want to just provide some of your thoughts.
And I can get, go ahead. Go ahead, Leslie.
Yeah, not a problem. So from strictly from a coding perspective, and as you noted, Chris, it is an open comment period currently. So I know everyone is working on our comments, including our organizations, but some general thoughts I would have, certainly anything that helps to reduce administrative burden, I'm sure would be welcomed by the provider and clinician community. I don't think that's necessarily an issue at all. I think in terms of the particular switches, I think things to keep track of is while you're putting on an add-on code to something, it can be wonderful, but the question is, are you inadvertently possibly creating a little more complexity now? Because every time I hear add-on, I think two possible levels of rules and guidelines to follow. And the question would be, is the way care is being delivered, does that help to reduce burden with that additional structure? Other questions, of course, or considerations I would have anytime we're dealing with both CPT and HCPCS, while oftentimes, those two don't necessarily have to completely come to terms and reconciliation on our desks, but for many of our listeners and viewers, it needs to come together on their desks in terms of working with both of these code sets. So that's also another question is, does it really need to be two additional systems, or is it really just working, say, of course, for me within the CPT code set to really get that collaboration to find a coding solution that is really going to help and reduce burden, not only in fewer rules, but potentially is there something that could be addressed with, say, in working with the editorial panel, and CMS certainly has a voice there, to be able to figure out, is there a way we could create a more consistent and easier coding solution with one set rather than temporary codes that may serve a temporary purpose, but again, that could be additional burden. And so anything to reduce those. But those are the initial questions and thoughts I have when taking a look at anything like this. Would be, is it reducing burden, and are you possibly creating complexity by having more sets than you thought? But Sulamita, I'd love to get your perspective from the practice on the ground perspective. What are your thoughts on this?
Yeah, thank you, Leslie. So, we're always pleased anytime we hear CMS integrating behavioral health into primary care. So that's always good news. And removing that time-based requirement could reduce administrative burden. So that also sounds great. But really, in the comments that we're working to finalize and submit, what we say is that we support those G codes be added to the APCM codes, but we urge CMS to apply or adopt some type of complexity modifier as a mechanism to balance the administrative simplicity of not having to track time, but also the need for appropriate reimbursement for those patients that have a higher clinical complexity.
Let's get to, we're just continue to get more and more questions, and so we'll see what we can get into. So I'm going to do some kind of rapid-ish fire kind of questions to try to get through as many as we can. But first, for either one of you, folks wanted to hear some more information about telehealth behavioral health services, specifically in rural healthcare settings, if you all had any additional thoughts related to those services and codes.
Yeah.
I can take this one from a collaborative care perspective, and Leslie, if you want to add something after, but really by design, collaborative care incorporates remote services as part of their care. So when services are delivered through telehealth, so we're thinking telephone or video, for example, they don't require a special telehealth place of service or a special modifier, right? When we're billing it as collaborative care services, because these collaborative care activities may take place in person or by video or by phone or even through secure messaging or the electronic medical health record. So CMS does not classify collaborative care as necessarily a telehealth service, but instead it's included. Leslie?
I would say from a coding perspective, really when it comes to telehealth and telemedicine, again, anything that helps to increase access to care for patients, is certainly welcome. And with regards to telemedicine services, a lot of what we've heard is that the codes that we have in our Appendix P and T in terms of they can be reported using modifiers for audio or audio video only in a telehealth environment, that they may not always necessarily align up with what's on, say, CMS's or any other third-party payers' telemedicine list. Now, a lot of that is payer policy, but I think anything that can be done to help have a little more alignment, again, reducing confusion, because we think about CMS, but certainly there are other payers as well. And you may have 3 payers and 5 sets of rules that you have to work with. So anything to smooth that out, I think would be definitely welcome. And I think that's regardless of the setting, whether it's a rural setting or any other setting where those things need to come together.
Fantastic. Can either of you share some examples of when interactive complexity or the code 90785 might be reported?
Okay, well, I'll definitely take that one on. It's actually it's not an extremely popular code, but the good thing, one of the things to think about is what the idea of interactive complexity is. So it's referring to communication factors that complicate the delivery of a psychiatric procedure. A few things in there. So, and there are some common factors: more difficult communication with discordant or emotional family members, engagement of young or verbally undeveloped or impaired patients, typically folks who require third parties such like parents, guardians, other family members, agencies, court officers, people who require that level of interaction with, in addition to the patient and the practitioner, might be eligible for this. Now, I won't go into a lot of details. I know we have lots of questions to get to today, but in terms of when it might be reported, the guidelines do actually outline a few areas, and they talk about this code can be reported with interactive complexity when at least one of the following 4, I'll say one of the 4 is present. So one is you need to manage a maladaptive communication style, something that complicates the delivery of care. Typically, this is something that is not typical for provision of that care. Number 2, caregiver emotions or behavior that interferes with the caregiver's understanding and ability to assist in the implementation of the treatment plan. You've got evidence or disclosure of a sentinel event, and that requires mandated reporting and all of the complexities that it comes with that. Or if you need to use something like play equipment, other physical devices to communicate with the patient to overcome some barriers, perhaps for a patient who has not yet developed or who has lost the expressive language communications to explain their symptoms and to be able to work with the clinician. Again, there's more detailed information in the guidelines, but those are kind of 4. One of those 4 will need to be present. So the guidelines give you that outline. I think the key thing here is to remember that it's something that is not necessarily typical in terms of working with the patient. I think there might have been an ancillary question might have been around this code as to whether or not the reporting is different for adults versus pediatric patients. And obviously, if you're working with pediatric patients, perhaps some play therapy might be appropriate or normal for a 2-year-old, a 3-year-old, if you're in that age range. But this is really trying to capture things where it is non-typical. So the guidelines actually give you quite a bit of information to help with you. The other thing to remember is that that interactive complexity is designed for use with the psychotherapy codes. And we know sometimes E&M office visit codes can be used. This is not to be used with an E&M code when there is no psychotherapy service present. So non-typical with the psychotherapy service, and the CPT rule gives you guidelines. Sulamita, I'd love to hear what you've seen in practice around this one.
Yes, I definitely seen that mostly, but doesn't mean that it's only with practices that work with the younger children where they need that play therapy is where I've seen it most in my experience.
We have another question specifically around whether behavioral health physicians can bill G2211 when billing 99202 through 99215.
All right, another excellent question, and one I've heard from a couple of different areas. Now, this is a HCPCS code, so I'm going to rely quite a bit on CMS's guidance on HCPCS codes for this response. But in terms of what I'm understanding, G2211, I've heard it phrased a number of different ways, but it's designed to capture the inherent complexity of the office or other outpatient E&M visit that's derived from the longitudinal nature of the practitioner-patient relationship. I've heard it phrased more colloquially as to the practitioner, are you the quarterback? So when someone says, someone really needs to take a look at long-term care and you're talking with the patient, you say, well, I'll refer you back to perhaps your primary care physician or whoever your main physician is. The idea is to question and say, is that you? That might give you an idea as to whether or not this is appropriate for you to report. Now, what I think is key in this instance is that G2211, as currently structured, is designed to be an add-on code. And so when you're looking at reporting relationships, it's not necessarily just G2211, it's what's the main code that it is to be appended to. In this case, CMS has defined that as those office or other outpatient codes. So in terms of who may report, what you want to do is take a look and see who may report those office or other outpatient codes, because that's going to drive where this shows up. Now, CMS gives a lot of additional information about how to report it in a group practice setting where perhaps the patient is seeing multiple practitioners, or how it works particularly with the rural clinic area. And I know there's some special rules there, but I think in terms of who may report, the key thing I would say is remember it's an add-on code. Who may report those base codes, because that's going to drive a lot of the rest of what you'll see. Now, it's interesting because I've heard varying levels of people reporting this. In some cases, it may be that it's been reported a lot less, perhaps, than what was presumed. And it may be that there's a little bit of confusion about how exactly to report that. I don't know, Sulamita, what you've seen in terms of kind of on the ground practice. This is one that seems to be a little bit of a head scratcher for quite a few people. So what have you seen in terms of actual use of this code?
Yeah, Leslie, I think you're exactly right. I actually don't have as much experience. It seems to be not a commonly used code. But the only thing that comes to mind, in addition to everything that you just mentioned, is if you're going to use this code for other payers other than Medicare, right? To really think about payer coverage and ensure that this is a code that is also covered by those commercial payers or their state Medicaid agencies if you're working across, say, a broad payer mix with your practice.
Fantastic. All right, we're gonna keep on going, see how many we can get to. So another question we received is how to leverage billing collateral contact instances, such as speaking with families, teachers, etc. And is there a possibility to use care management codes specifically in the hospital setting?
Yeah, I can start with this one, Leslie. So this is again perfect space for collaborative care, and think about how we can use those collaborative care codes because they account for time spent by the behavioral health care manager engaging in clinical activities. And that really involves activities with families, or if we're talking about the pediatric populations like teachers or school personnel, if they are directly related to that patient's treatment, right? So care coordination, outreach to communicate and communication via electronic health records or phone calls or secure texting, all of that counts towards clinical activities that the behavioral health care manager can count towards collaborative care minutes. Now, CMS, after the CPT codes were turned on in 2018, later clarified place of service 19 for the off-campus outpatient hospital and place of service 22 for the on-campus outpatient hospital are also places of services that are included for collaborative care codes. So these includes both facility and non-facility types of settings. Leslie?
I would say what Sulamita just said in terms of the comprehensive nature of use of the codes. Certainly won't comment on specific third-party payer policy, but the idea that those codes are designed to encompass a number of different types of communications. And I know that within our guidelines, we have some pretty extensive guidelines about what to look at from a purely reporting perspective. So, but it's great to hear that those are in use and of particular benefit, really to bring in those additional perspectives for the care of the patient.
Fantastic. All right. I'm going to try to loop some of these questions together, and Sulamita and Leslie, do your best to answer some. But I think there's a lot of questions about the different types of clinicians and other folks and who can bill what. So there's one question specifically around clinical psychologists and E&Ms. So e-consults, care managers, what are they able to report on? There's also a question around LCSWs and anything they might be able to do, particularly when they're in their supervisory period. And then lastly, there are questions specifically around certified health coaches who are contracted with physicians, and what types of codes might they be able to bill out. So I know that was a lot, covers a lot of different topic areas, but hopefully you all can pick and choose the ones that make most sense to try to answer.
And Leslie, I'll let you start on the E&M side, and then I'll tag along on the back with like those certified health coaches and LCSWs in training.
Okay, sure. So I'll take a swing at this one, Chris. So for the E&M physicians, you talked about codes that can be reported by clinical psychologists within the E&M areas. Okay, and some of this goes back to one of the slides that we had previously. We don't need to bring it back up, but just to note that this is going to be, if those slides are available as handouts, people will be able to find it. Again, CMS has determined that there are certain levels of practitioners. I believe it's 5, and I probably won't get all 5, but I know that physicians, physician assistants, nurse practitioners, and there's at least 2 more, are eligible to report E&M codes. So, and in this case, probably the ones that will be impact most are your office or other outpatient codes, our new telemedicine codes, and they've always been in the E&M section. But again, what we've done is, because sometimes there are certain categories of individuals who don't fit in that definition of physician or other qualified healthcare professional, and I'm looking to look up the official definition right now, that CPT has created parallel codes that relate to certain types of services rather than an evaluation. It's an assessment and management of the patient in certain settings. So you do have telephone codes. And again, if you looked at our previous telephone codes, they're almost an exact mirror of those codes. So there is a reporting mechanism there. The online digital services, the e-consults, the e-visits that we typically have, that's another one that there is an E&M set, and there's a parallel set for those who may not report E&M. So we allow that flexibility. And then also, again, the remote therapeutic monitoring services, which are a little bit beyond the scope of this webinar. But we do have some parallel codes that are available for people who may not meet that QHP definition to allow them to still work and assess their patients. So that's the first one. I don't know if Sulamita, you want to start with another one? That's a perennial topic that comes up, by the way. So
we'll
no
bounce
worries
it
there.
back and forth. Absolutely. Thank you. So when we think about LCSWs in training, and really I'm just going to bring in that certified health coach here, because the same thought process is going to apply, even if the answer may or may not be ultimately different, right? So For collaborative care, Medicare defines that behavioral health care manager as someone that has, quote, formal education or specialized training in behavioral health services, right? And then they list it could include a wide range of disciplines like social work or nursing or psychology. But what they didn't do was specify a minimum education requirement, right? Or a minimum licensure requirement. So, depending on what's meant by that LCSW in training or that certified health coach, they may meet the requirements to be a behavioral health care manager under collaborative care. But we have to keep in mind that payer mix of your organization, right? If you're serving more than just more than just Medicare patients, what are your state Medicaid requirements? We've seen that sometimes they are stricter than Medicare. Sometimes they do have minimum licensure requirements for that behavioral healthcare managers. And what about those commercial payers? Typically, they follow Medicare guidelines, but really ensuring that every payer that you intend on billing and the guidelines for each one of those matches the role of this behavioral health care manager.
All right.
So
how are we doing on time, Chris?
Yeah, we're right up against it, but I'm trying to sneak in a couple extra ones because I know everybody's super enthused. So we'll see what we can do. So one question, and we'll see if we can get to another after this. But there's a question specifically around preventative medicine codes and asking whether those require diagnosis codes, and if so, if you all are able to provide any examples for those instances, and you can let me know whether that's something you are able to tackle in this discussion or not.
Okay, well, I'll take the first swing at it. From a CPT perspective, I wouldn't necessarily be able to give strict guidance on diagnosis coding. That's ICD-10 diagnosis coding. Although if it's something like preventative care, I am aware that there are codes around patients coming in for screening for XYZ or, annual exam. There are some codes that relate to patient coming in to receive certain types of services where you don't necessarily have a particular medical or a physical diagnosis. I know those available, and I would presume that those would be the types of codes that I would expect to see on a claim. I couldn't tell you exactly which ones they were, but those would be the types of codes. I think they were in the Z series, if I remember, that I would expect to see on a claim of this type. I don't know, Sulamita, what you've seen in practice, if that's what's been used or if there's something different out there.
Yeah, when we think about Z codes for diagnosis, and again, I'm just thinking about it from that behavioral health, collaborative care integration space, there are many payers that do reimburse for collaborative care and behavioral health integration when using those Z diagnosis codes, but we have got to come across some particular state Medicaid agencies that may have a limited set list of diagnoses that they reimburse for and do not include those Z codes. So that's what I've seen on my end.
All right. We're going to get to one more. So the question is it appropriate for mental health providers to bill CPT code 96127? Or is this code meant for more primary care providers, since these types of assessments usually include in their evaluations when doing therapy or medication management?
Well, I'll take the first swing on that one. So when it comes to 96127, again, that is, if I remember, this is a brief emotional and behavioral assessment, the short version of that code. In terms of reporting, what we've seen when we take a look, and it's limited with Medicare data, admittedly, but oftentimes it looks like it's been, most of the time it's reported with an E&M code. Usually the 99214s, 215, some of the higher level sessions. In terms of who may report, the specialties I've seen come up most frequently and wouldn't be surprised with the E&M codes are your family practice, I believe some of the nurse practitioners may show up, but if it's being done in conjunction with an E&M, that would make some sense. In terms of who may report, I have seen licensed clinical social worker. It doesn't appear to be at the top of the list, although it does appear. But again, that could also be a byproduct of where this code is reported, where it's used. It's all, again, the majority of the time it's reported with another E&M code. It's just, it doesn't seem very often that it's reported in isolation. So that may limit where in the care continuum that actually is appropriate to do and what it's paired with. Sulamita, your thoughts?
Yeah, Leslie, I'll second that. In my experience, I've mostly, or really, I've on my end only seen it paired with that E&M code. And in addition to the providers that you mentioned, I've also worked with psychiatrists who are billing that E&M code and also add in that 96127.
Well, I think we're running low on time. I know there's a ton of other questions, but I know in the comments, we're going to, on the AMA side, aggregate all of these and do our best to respond back to folks. Or I know, Leslie, there are other opportunities that CPT has in terms of helping answer some of these very specific questions. I don't know if you want to talk about that briefly.
Sure, absolutely. So in one of my other hats, in addition to webinars, we also prepare information and coding guidance that you will see if you are a user of our knowledge base area or advanced coding pack, or if you read CPT Assistant and there are questions and answers that constantly show up there. I and my teams are responsible for the information that goes into those as well. And we're always looking for questions that are issues where we can help to reduce confusion in the coding community. And we'll definitely be looking at the ones we couldn't get to today. Do we have trends? Do we have key topics that you might see show up in another venue? So don't feel that this is absolutely the end. We will take inquiries from all types of areas because there's never a shortage of questions, and we'd like to try to get to as many as we can. So please don't feel that it was used in vain. It may pop up someplace else.
Absolutely. So with the last few minutes we have, Sulamita, do you have any last kind of pearls of wisdom or other kind of parting thoughts you want to have for the group? And then Leslie, we'll kick it back over to you to share any last thoughts you might have with everybody.
Yeah, I'll for sure say that what we've seen is that support is very important when it comes to implementation of any new service for a practice or an organization. So reaching out to experts like Leslie, looking for that technical assistance, right? Organizations that are subject matter experts in whatever service you're trying to implement is always going to ensure that that implementation process is successful and that post-implementation remains successful.
And I think in terms of last comments for me, certainly as we go through and as everybody works with, the reporting period for the final rule and we're distributing the 2026 code set, there's always something going on. But I would definitely appreciate everybody's participation here. I'm so glad to see everyone on the line. And again, all of your wonderful questions. While we can certainly work, through the editorial panel, others to modify and update and revise codes, it is always helpful to hear from how these work on the ground. And Sulamita, kudos to you for giving that input of how it really works to make sure that we're hitting those marks and helping to improve the clarity and the use of CPT coding and improve its use for patient care. So always looking forward to hearing from everyone about how it's really working so we can work to continue to improve it. So love opportunities like this. Thank you so much.
Fantastic. Well, thank you all both so much. This was a great discussion. It's clearly just the tip of the iceberg on this topic area, so more to come. And again, please always reach out to our team, to others, as you have additional questions, and we will all work to do what we're here to do, which is to help you all create better care experiences and care access to the patients that you're serving. So thank you so much today, and I'll pass it back over to you, Alec.
All right. Thank you to the three of you. And for all of our wonderful attendees today, I am loving seeing these emojis just absolutely pop off. It's good to know you're all there. Just so you know, we received well over 100 questions just today and dozens more during registration. So if we didn't get specifically to yours, we apologize. We are constrained by time. But as Chris mentioned, we will do some sort of aggregation, get some big picture answers out to all of you as soon as possible. Another big question that continued to come up was about how to access today's slides. You can do that Right here on the screen, you should see the kind of widgets that you are viewing if you are on Zoom with us. There you'll be able to find a selection of resources, including the slides, which are in the Documents tab. I did put in the chat for everyone a note that our BHI Compendium link, which I hastily added at the last minute today, did not copy correctly. So in the chat is the correct link so that you can view that if you wish. I will also update the Resources tab for you to view if you are viewing on demand, which you can do with the link that you joined with today. You will also be able to see this later on the Ed Hub, where, of course, you will be able to claim CME, as I mentioned earlier. Now let me go through a last couple of things here. Our next webinar is how to integrate behavioral health into value-based care, and it's going to go live on Thursday, November 4th. You can join our panel of healthcare leaders as they share real-world examples and lessons learned on how to address the challenges of behavioral health integration, as well as actionable considerations for the future of whole-person care and value-based care, value-based arrangements. If you would like to attend, there is a link in the Resources tab for you to register all in one step. You can also join our hub where you can see other webinars that we have coming up this year. When we conclude, you will see our feedback survey. Please take the time to go over the 2 questions there. Your responses really help guide our upcoming program to deliver webinars you want to see, such as the one that you saw today. And like I said earlier, this recording will be available for you to view on demand using the link you joined with today, later on our YouTube page or on the AMA Ed Hub. For any additional resources and guidance to support your physicians and staff, including those working to integrate behavioral health into your practice, please visit the American Medical Association website or stepsforward.org. We thank you again so much for joining us and hope to see you again soon.